All right, so I'm going to use the faculty as a panel, and I'm going to start with this case of a 54-year-old male. He has some CKD. His eGFR is 32. He presents with gross hematuria, and he gets a CT scan. And so, Jonathan, what do you see here?
Sorry.
There's an arrow, so that should help you. Sorry, okay, next, okay, yeah. Yeah, it's so 54-year-old male, CKD, gross hematuria, gets a CT scan for a gross hematuria workup.
So it's like really irregular appearing infiltration and some mass. That would be concerning for different things. Is it the same picture, the same patient?
Yep, same patient, just the coronal.
Yeah, so that could be an aggressive, renal cell necrotic or a epithelial cell or something different. Like that was that like an infiltrating mass. Not like lymphoma necessarily, but looks concerning enough to consider either a biopsy or how's the patient doing now? Lots of gross hematuria.
It's not terrible. He's got, it's pinked up a little bit. He had a bout, it's kind of resolving. So his hematocrit's fine.
Is that stented as well?
Yeah, he's got a Foley in there. So actually a stent, sorry, he's got a stent. He's been stented.
So is he a smoker? Is this guy
Smoker.
a TCC?
Yeah.
So I'd be worried about a high-grade TCC in this case.
Okay.
So I might consider doing uroscopy, or at least if you have a drainage film where you can see the collecting system, pushing the collecting system out of the way, or
Well, here's a couple more cuts. So here's a cut. So you get a little farther down in the CT scan, you see the kidneys kind of come together, unfortunately. Here's another cut. So you can see he's got a high grade. So he had a renal pelvis tumor in the left moid of a horseshoe kidney. This was high grade TCC on ureteroscopic biopsy. Metastatic evaluation was negative. Fortunately, the left moiety is not the great kidney, which is good news, but he has significant renal dysfunction, and we need to save whatever we can. So, options. Jonathan, this is your case, I guess. What do you want to do?
Well, I mean, from a cancer standpoint, he needs a nephrectomy.
Right.
He's not going to be able to get cisplatin at that creatinine.
Right.
So I don't know whether he was probably not going to provide benefit. So.
Yeah, they could give him carbo and gem, cytidine, if they wanted to. Yeah.
Yeah, so I think the nephrectomy, I don't think it's a horseshoe kidney, but it's a typical surgery, but we
Okay. Ronnie, what would you do?
I think the same thing. I think he doesn't have to do.
Caden, any thoughts? Anything different?
Endoscopic, reasonable option.
Right.
There's no, I mean, you're right, you could do carbo, but that's in preparation for FU.
So you do it open, robotic, what would you do?
Carbo's not a substitute for cisplatin neoadjuvant.
Right,
Yeah, so it's a no for neoadjuvant.
yeah,
I do this robotic.
okay. All right, so that's what we're gonna do. So just like you saw today, similar port configuration, just a little different anatomy. So drop in the colon, and then you can see the left moiety kind of sticking out there, kind of low in the abdomen. And the very much like we did today, we went to the ureter first and just mobilized it all the way down, clipped it, did the bladder portion first. So you've seen all this ad nauseum today, so you pretty much should know how to do this after today. Had the stent in place. So did the repair. And of course, this is kind of the not challenging part of the operation, because the horseshoe kidney is going to be a challenge. So we filled it up, tested it, so it was watertight. So now we're going to go find the anatomy. And of course, the horseshoe kidney anatomy is quite variable. We did find this is actually one of the main vessels going to the left moiety. This is a vessel that was medial, but this is actually the vein, so we stapled the vein. But there were other vessels as well. So we've devascularized it some, but we used ultrasound then to identify really kind of where the isthmus was. And you can see the collecting system there, and it goes away as you come more medial. And right about there, pretty much right over where it crosses the aorta, that's the aorta right underneath it right there. Right where it crosses the aorta is where we're going to divide. So we just made a mark there for the ultrasound. And there was a vessel here feeding the area. We thought we might be able to save it. So we clamped it, we gave ICG, and then we could see that indeed it was feeding that area. So you see as we come off, we get a nice blush there. So we know that vessel's got to go. We can't save that if we're taking out the left moiety. So we were trying to save as much as we could. We thought maybe we might get away with it, but that vessel's gone. And then it's just a matter of coming across now that the kidney's pretty much devascularized, you can pretty much do the division at the isthmus and then just suture it.
So Jim, did you have to medialize your ports at all compared to your normal FOU?
And pretty much use the same configuration because we're pretty medial on that, to begin with, because we actually are angling down. So we really didn't change anything really. So patient did well. Home on day 1. It was a large tumor. Lymph nodes were negative. T3 N0. Fortunately, his creatinine did not budge very much, and he's done well. So in the second case, 67-year-old male with pain after colonoscopy, got a CT scan, found to have a tumor. Caton, what do you think of that tumor?
It's funky.
Yeah.
It's funky looking. I mean, it looks solid, but.
Yeah. Yeah, it's not a good tumor. Here's the coronal. So pretty medial. So 4.6 centimeter left hilar tumor. Creatinine, again, has some renal insufficiency. Metastatic evaluation was negative. So again, what would you do here?
Yeah, I mean, I would still rule out TCC, but
Mm-hmm.
urogram and cytology.
Right.
But it doesn't look like TCC.
Right. Yeah, could be. Yep. So cytologies were negative. Urogram looked fine. There was no filling defects.
Yeah, so, yeah, that's it. So it's.
Do you do a radical? Would you do a partial? He's got renal insufficiency. He's got an indication.
No partial. I
Yeah.
mean, again, you approach these in a way where it's complicated but possible, may
Mhm.
not happen.
Right.
But setting out to do a partial is very reasonable that they're doing it.
Right. Ronnie, any thoughts?
Can you go back to the coronal?
Yeah.
So I think this is very partialable, but obviously it's right on the renal pelvis. So one of the first things that I'm going to do when I go and do this partial is I'm going to go between the renal pelvis and that medial edge of the tumor and make sure I can get between there. If I can get between there, then I know I can get around it and get that lower part of the kidney off. So I think it's very partial. And I think I would do it for this guy because of his GFR.
Right.
So also, the other option too, and I've done this once before, is you can actually cut out.
Yeah,
You can reconstruct it.
Mm-hmm.
I don't know if that's a limiting factor.
It wouldn't be, but I mean, it would give you that side of the tumor very easily. If you get between the pelvis and there, which it should come right off, then now you've got that whole side of the tumor done, and then you have to come between the tumor and the brain, lock it off.
Okay. So we elected to do exactly what you're saying, a left robotic partial. We use a transperitoneal approach, and again, the linear port configuration. So as Ronnie pointed out, we looked to see if we can get around the tumor and used ultrasound to kind of guide our margin here. And so we've got the tumor pretty well identified. We're going to clamp the artery and the vein in this case, as it's a central tumor. I tend to clamp the vein. And as we're doing this, we see something here. So what would you do there? I'm trying to stop this, it's not stopping. Well, I'm trying to, anyway, start over. So what would you do with the thrombus? I mean, how would you manage that? What would you do?
So you've clamped the vein already. If you
Right.
didn't, I would clamp the vein. Let it bleed out and empty out so you can see what's in there. And then you can either ultrasound or you can cut the vein open further to make sure there's no more thrombus. Rarely, if you don't see it on preoperative imaging and your imaging is reasonably, within 3 months, it's hard to believe it would extend very far outside the intravenous portion. So I think what you did is exactly right. You let it bleed, you saw the end of the thrombus.
Right.
You could check it with ultrasound if you want to just be sure there's
Right.
more.
But we're clamped at this point, so,
Yeah,
yeah.
and your thought is radical or not.
Right.
You're clamped, but
right. Well, and that's what we were thinking. Should we do a radical or
yeah,
or
so
not?
you're clamped, so your decision is can
Yeah.
you take part of this kidney and take a little extra ischemia time. And,
Mm-hmm.
this goes back to what I'm saying. Then take the ischemia time. It's still better to have something than nothing. So yeah, but that was beautiful. I mean, you got to the bottom of it and you got it out.
So,
We don't have, we obviously don't have data on this, but I would venture to say that your oncologic control would be no better with a radical nephrectomy than what you already did.
yeah,
I can't prove it, but
right,
that's what I would say.
right.
So no, I think you did the right thing.
Yeah, and there's the bolster, so that helps when you have a hole in the vein. So we just finished the excision. And I'm a fan of bagging specimens, especially when there's a tumor thrombus hanging out. And then this is the rescue stitch that we were talking about. So I've got a Lapper tie on the end, and this is a Proline. And we actually made this when we saw we got in the vein. And as I mentioned before, you can just take off a Lapper tie and just tie it, and just a little more aesthetic, I guess. It probably doesn't matter either way. And then just do our regular closure. So we got in the collecting system, so we're just closing the collecting system there. And then the standard closure.
You following this patient still?
Yeah, oh yeah, I've seen him. So we're doing close follow-up on him.
Might be an argument that for these central tumors to kind of always ultrasound the vein
Mm-hmm.
when you have your ultrasound in,
Right.
just because that's where the risk is.
Yeah, and we did that, and we didn't actually see that until we kind of got the tumor out of our way, and there it was. So, but he did well. Turned out to be a T3A with negative margins. His GGFR dropped some, but he's actually doing quite well. So third case, 68-year-old female, 3.6 centimeter right renal mass, normal creatinine, most of the kidney, 55% in the right kidney. She's got some cardiomyopathy, and then she's had a hysterectomy. So she underwent a CT scan for abdominal pain, and then you can see this mass in the right kidney. So here we are on coronal. So nephrometry score is 10x. So Ronnie, what do you think of this one?
I think it's partialable.
Uh-huh.
I don't remember what her renal function was.
It's good. She's got good renal
I
function.
wouldn't fault anybody for doing radical
Uh-huh.
nephrectomy, but I think it's partialable.
Yeah,
She's
okay.
open to a partial. The challenge is going to be the arterial branches that are around it.
Mm-hmm.
So you're going to have to find those, deliberately find all
Mhm.
those arterial branches, make sure you can get them away from the tumor.
Mm-hmm.
And then you're going to have to take a tight margin because you don't want to knock off those branches
Right,
cutting into it.
right. How would you approach it?
Transcranial.
Mm-hmm. Okay, Caden, what would you do? Same?
I mean, so the considerations are, this is sort of a mid to posterior above the hilum, right? Is sort of what it is, which
Mhm.
is a very challenging spot.
Mhm.
I mean, I agree, I think I would go trans and kind of come from behind the kidney, but
Mm-hmm.
if you look at where it is, right, it's above the hilum,
Right,
more to the back than the front.
No, it's like right in the middle because look, the vessels are coming in this way. So it's literally right in the middle of the kidney.
So
yeah, I kind of agree with Caden. The vein, the main vein is kind of covering this. The main renal vein is covering this.
Okay, maybe I.
Yeah, yeah. So,
it's a very challenging.
yeah, it's in a bad spot.
This is
The question is, which way do you approach it if you're going to do a partial? And that's what we were kind of trying to figure out. So because of the vein, we decided to approach it retroperitoneally, of course. And so I'll show you that. So I don't think a radical is wrong here. And so we attempted it retro on the right side. So as we showed you earlier today, the first step is just making that incision in Gerotis fascia, entering the space where the kidney lives, and that's what happened here. And once you're in that space, you can see it's like a bag, it's like a sack. And then the hilar dissection, I think is everything in this case. It's really not just finding the vessel, it's finding the vessels as they go up to the tumor. So we started out just identifying everything we could. There actually was not just there was actually a lower pole artery as well. It ran parallel to the ureter, so it was very confusing for a while. We weren't sure exactly if that was an artery or not. But there turned out that right there you can see there, it looks like the ureter, but there's actually an artery that's running right with it. You can see they're right together, the ureter and that artery. So I want to thank Harsha for doing the edit on this. He did a great job. So the mass is kind of still covered, and the trick here, of course, is to get in that plane between the tumor and the sinus. That's where you gain a lot of space, and that's the back of the main renal vein right there. So you can see the tumor is kind of abutting. So I think in retrospect, I was glad we went retro, because the only thing that was really in our way was the posterior branch of the renal artery. Everything else was anterior. And so we found those branches, and again, just dissecting it off the mass. Now, I like to do this for these complex tumors. I like to suture. You could get a suture on a very small spot. You don't need to do a lot of dissection, and they stay on. They don't fall off. So I'm a big fan of sutures for these complex vascular ligations. This is way deep underneath the tumor, so we're way up in the sinus now, way underneath, and we're doing all this before warm ischemia. And so the more you can do of this before you clamp, the better chance you're going to have of getting this out in a nice way. There was one branch we actually had to take here. It was crossing, and I figured if I take this one branch, I'll be able to swing that artery all the way to the upper pole, and then I'll have this little window. So we clamp the lower pole artery, we clamp the main artery, and then I move that artery all the way, and now we're just making a radial nephrotomy, if you will, through the parenchyma, and with mostly blunt dissection, you can get the mass off. And I think Ronnie's point about being careful about the branches is really important, because if you're not careful, you can just devascularize the whole kidney while you're doing this. But if you do blunt dissection, you can actually see these structures and you can preserve it. So that's a collecting system I'm basically holding against there. So you can see it just kind of shelling out like a Tootsie Roll, and just keep doing the blunt dissection and it frees up. So there's an entrance into the collecting system right there, so I'm just suturing that. And again, this is where I think the individual suture ligation technique that I use really pays off, because you can't really whip stitch the base of this defect. It's not a technique you can do with this kind of, with the vessels that are there. So coming off that lower pole artery first, just to see if we have any bleeding. So we're doing, if you will, early unclamping. But it's really to see, if there's any bleeding. And we really want to make sure we get everything closed before we finish this.
So these deep cave type defects, you're exactly right. You got to early unclamp to make sure that's how you get a pseudoaneurysm.
Right.
For sure.
Right.
Because it is just a big open space, even if you're closing.
Right. So I never put a bolster in or use Surgicel, but there's a fair amount of dead space in this case. So I put some Surgicel in there and just close over it, and it did fine.
That's a great case. Beautiful.
Yeah. So we're going to give a little ICG at the end just to see what we've done with regard to vascularity. I think it's a good test. So here comes some ICG, and you can see the kidney's pretty well perfused. There was that one area you can just see to the right of the eclipse, a little devascularization. That was the branch we took, but kidney did very well. So it turned out to be an eosinophilic chromophobe, RCC, negative margins. Patient did very well. So switch gears a little bit here. This is a 51-year-old female with chronic right-sided flank pain and a history of recurrent pyelonephritis. And she was thought to have kidney stones, but she's never passed a stone. So she got imaging, and actually she got cystoretrograde. And she was found to have a duplicated system. And on what was found is she had hydro of the lower moiety, lower pole moiety, and she only had a single ureteral orifice. So this was a kind of a bifid ureter. And they stented this lower pole moiety, but she still had recurrent pain. She really couldn't tolerate the stent. So she got perked in the lower pole moiety. And when they did the perk, they found that she had pretty significant hydro in the kidney and a pretty narrowing, kind of right where the ureter meets the upper pole ureter. Here it is on a contrast image as well. So she has a history of a sigmoid colectomy in 1998. She's had 4 ventral hernia repairs, not 1, but 4. And she has a BMI of 33. So
this is when you do a retro. And in this case, I had a case very similar to this, and I did a pyelonephritis. So I didn't mess with the UPJ at all. I just connected the 2 renal pelvises, problem solved. That's what I would do. I do a retro though to stay out of her hostile evidence.
Right. Jonathan, you are the pyeloplasty expert. How would you approach this?
So is the upper pole?
Upper pole looks normal. It's not it's not hydronephrotic. Looks like it drains well. There's good parenchyma around there. So the upper pole looks good. So you always worry about risking, injuring something that's actually doing pretty well.
And so there's no, because Ronnie was saying maybe put the 2 renal pelvis and lower pole and upper pole. Is there an extra renal upper pole, or is it just like?
It's just the kind of the ureter coming down, past it. So technically, Ronnie, how would you get that renal pelvis to go to renal pelvis? Yeah, and the side. Okay.
Kind of like this.
Yeah. Yeah.
We don't need any crossing vessel or anything? Or,
No, there was no crossing vessel. This is just an intrinsic obstruction. Would you consider a partial nephrectomy?
How much function? Was there a lot of function from that lower pole?
There was some, but she's got good renal function, and it's hydronephrotic. But would you consider a partial for this kind of this issue?
Wouldn't give that answer.
Yeah. Okay. All right. So we didn't do that. We did a pyloureterostomy retroperitoneally. So we thought very similar to what you were talking about, that we would obviously stay out of the abdomen. And then you can see the kind of the anatomy coming together here. So this is her dilated lower pole moiety, and you can see I'm kind of dissecting it away from the ureter, and it's very obstructed. So I divide it, and nothing comes out. I mean, it's completely blocked. So we spatulate it, and then we're going to tie it into the normal ureter that's coming from the upper pole. So to me, that's why I ask about how you would get to the renal pelvis, because where I was at the lower pole, in order for me to get up north, into a much more dilated area, I'm not sure I could have done that.
So can you pause it for a second? So basically what I'm saying is that rather than having divided the UPJ, just leave that attached, who cares, and sew these 2 together. Make sense?
Mm-hmm. But you're still dealing with ureter, not so much renal pelvis. That was my concern. Is like,
well, you use pelvis, then you're doing pelvis, but if it's ureter, then yeah, it's ureter pelvis.
yeah, because that was the issue.
Leave the UPJ alone.
Right.
Sew the 2 together.
Yeah. Well, I figured I was going to die. I couldn't really get the renal pelvis on the upper. We looked for it. We exposed it, but I would have to swing that up, so I wasn't so sure I could do that. That's why I'd like that idea, because I didn't want to suture to the ureter, because I think there's more issues with it. But we really couldn't reach the renal pelvis, even if we had divided it. So we did that, and we stented her. And she did well. So we left the stent in for 6 weeks. Post-op renogram showed no obstruction, and her flank pain went away, so we were pretty happy with that. So actually, this is a 69-year-old male with a Bosniak 2 cyst. We followed it with ultrasound and did a CT scan with contrast, and it became a more complex cyst than we had seen previously. You can see it's on the upper pole posteriorly. So 4.2 centimeter Bosniak 4 cyst now, so it's got solid component as well. He had a prior left colectomy for diverticulitis, so you can see where this is going. Jonathan, what would you do with this 4.2 centimeter cystic mass?
How old is the patient?
Um,
I mean, so the cystic mass, even at 4 centimeters, although it's growing, you can still do surveillance. They're not thought to spread, really, cystic RCC, but if it looks like it's reasonable to approach retro, I think it's the CTA long enough to see is it posterior and retroperitoneal?
yeah, it's posterior. Mhm.
And that's definitely an option.
Okay.
Sure.
So you might follow it?
Right.
Okay.
Depending on the age,
Okay.
the health of the patient.
Okay.
For a cystic renal mass.
Uh-huh. Caden, what do you think?
I mean, go back to the first, keep going. This was.
69-year-old.
So over 4 years?
No, it's more like 5 years it progressed.
5 years. Yeah, I mean, it's big now, bottom line, and it's a 4. I mean, that's a gnarly looking Bosniak 4 cyst. So and he's 69, if he's a healthy 69, I'd probably treat him. I think these guys get very nervous when it grows like that.
Yeah. Ronnie, what would you do?
But surveillance is very reasonable.
Yeah.
I would probably treat him.
Yeah, I mean, I think people, based on his age, you might say, well, by the time this thing becomes a problem, he's gonna be 75. But the issue is that if you wait until then, it's a much harder partial or radical nephrectomy. So if you can go after it now, if the guy has a reasonable 10-year life expectancy, then the right time to go after it is now.
Mm-hmm. Yeah. He's healthy. He just has a cyst that we've been following. So obviously you don't want to biopsy it. Radical, partial, we've talked about all the other options. So we did a retro approach. And of course, these guys, the fat's not pleasant, but it's doable. Here's the ultrasound, which I think was telling. You can see pretty cystic with a pretty big solid component. I mean, that's a tumor that's not going to go away. It's probably going to continue to progress. So again, same ideas. He actually had 2 arteries. Give ICG, make sure we have complete ischemia, and then cut. Now, so Caden, for a cystic tumor, what are some of the considerations when you're dealing with these cystic tumors?
Yeah, I mean, the nice thing about cystic tumors is you can ultrasound them very nicely. They show up, you can see exactly where they are. The problem and the concern is rupture, right? Especially a big one. When you get to 4 centimeters and you're trying to get around it, rupture, this is just a problem. So my personal way of dealing with that is I'll take a little extra margin, right? So you get a little bit of the tough parenchyma around it that you can push on with your left hand. And I've seen it enough times where if you don't do that, you just inadvertently go right into it. It's so thin. So take a little extra margin. Use your ultrasound because it's as good as it gets with these cystic tumors to see what the margins are. And just take a little extra so you have some strength to it when you go around it. The only other point I want to make is although retro is an awesome approach to all of this, diverticulitis, non-perforated diverticulitis for colectomy still, shouldn't preclude you from doing trans. It's usually not an issue.
Right. Ronnie, anything to add? Cystic, Jonathan? Okay, so yeah, I think that's a great point. Rupture is, I've had a rupture, in one of these. It's not fun. You worry that when you're doing that, and it can just happen because and you're not even really thinking about it. You're just pushing, and all of a sudden it's just. So I think they're very hard tumors. I think they require a lot of care. They require that margin of safety of getting additional a border there. And so, yeah, we went pretty deep. Even though this didn't look like it was in the collecting system, we extended our margin so that we had that little extra border. Yeah, so it's barely got in the bag. But again, a cystic tumor as well. I wouldn't want my assistant to inadvertently bring an instrument in with a tumor there. I want to get it out of the way. So again, it does require more care when you're dealing with these cystic tumors. So you guys have seen all this. So did well. It was a Furman 3/4, so this was not a nice tumor. Did well, lost 4% function based on renogram. So with that, I'm going to conclude, and I think we will wrap up, and we'll leave anything open for questions for anybody from anything that was talked about today. So any questions from anyone? Please.
For radicals, is everyone doing robotic or are you doing lab? So the discussion should be robotic.
Right. So Ronnie, I know you've talked about that many times. You want to give your thoughts on that?
Sure.
So I'm a big believer in robotic nephrectomy, and I've been doing it forever. So I've been doing all my surgeries robotic since 2008. So I've got 10 years of robotic nephrectomies, and I got to tell you that back then, doing robotic nephrectomies was highly criticized. People were saying, you shouldn't do it. You should do it lap. You should do it hand assisted. You're just wasting time. It takes longer. You're wasting money. It's more expensive. But the argument that I made at the time was that, doing it robotically, I feel I have more control. It makes me better at partials. I feel I can do it just as fast, maybe faster, but also that it enables you to do more complex nephrectomies that you wouldn't necessarily be able to do laparoscopically. So it reduces the number of open cases you have to do. And by doing all of my nephrectomies robotically, that's what eventually allowed me to do the complex stuff like caval thrombus and invading liver, invading pancreas, all of these other kind of locally advanced tumors. And then tumors, the largest one I've done was 30 centimeters. I don't think I would have been able to do that laparoscopically. So I'm a big believer in radical nephrectomy done robotically. We looked at the cost when I was at Ohio State. We compared lap with robotic, and we actually found there was no difference. If you don't count the cost of the robot, the fixed cost, so the depreciation cost of the robot, the annual depreciation, and then the maintenance cost, if you don't count that, meaning you already bought the robot, it's there, it's available, you either use it or sits there, or gynecologists use it for hysterectomy or whatever. You own the robot. If you just compare the case on disposables and whatever, it's actually the same as a laparoscopic, because I was doing my robotic nephrectomies without a stapler. Again, I just used the Hem-o-lok clips on the artery and vein. Whereas the lap guys were using more disposable ports, they were using a stapler, they were using a ligature or a harmonic, all of these things add up. So we found actually there was no difference. So then a couple of the other guys at Ohio State then started doing their nephrectomies robotic. When they realized that it was no more expensive, they started doing their nephrectomies robotically. So Caden actually has looked at this in terms of what proportion of US nephrectomies are done robotically, and it's going up, without a doubt. It's going up. Maybe he can tell us a little bit more about that. So I think it's catching on, and I think when people talk about the benefits of doing lap nephrectomy, one of the arguments they make is, well, we got to train our residents how to do lap nephrectomies, so that's why we're doing them lap. And I say, your residents don't want to do lap nephrectomies. Your residents want to do robotics. They want to learn robotics. Use the nephrectomy to teach them how to do hilar dissection and how to do whatever for partials. So I'm a big believer in robotic.
Yeah, I think your points are all right. And the only thing I would add to that is, the concept of, when we're first doing robotic radicals, it was, well, it's learning how to set up the patient, put the ports, dock, do a hilar dissection. It's the same steps as a partial, except you're not doing a partial. But I think now we do enough partials and there are less radicals, and so that's less of an argument. So we wrote in, there was a paper that came out, I'm sure you all saw it in JAMA, that we wrote an editorial to that basically showed that, robotic radical was more expensive than lap, and, don't do it. And we wrote a response, which was the first time a response has ever been accepted. And the point was, all right, well, here are the last 5 radicals we've done, right? We did a retroperitoneal lymph node dissection with the big tumor. We did a level 2 caval thrombus. We did someone who had a prior partial, and then we went back and did a radical. So just pointing like these complex, one that invaded the liver that we did a partial hepatectomy on. So these are the radicals that we're doing with the robot. So all of the easy tumors are being done partials, all the medium tumors are being done partials, and a lot of the hard tumors are being done partials. So what are you left with to do a radical on? Really, really bad tumors. So it's nice to have a robot for getting in the cava and other things. So then the only easy radicals we do in our place are pre-kidney or pre-transplant kidney tumors. Right? So a tumor in a patient that's a pre-transplant eligible patient that needs a radical nephrectomy to be eligible to get transplanted. And that is the easiest radical nephrectomy you'll ever do because they're atrophic, they're easy, that's the small tumors, it's as easy as it gets. And if I polled my residents and fellows and asked them how they'd want to do it, 99.9% of them will do it robotic because that is the perfect case for them to do and love to do and learn how to do, and it's fast. And I'll tell you, if you put me up against our best lap person to do that type of radical, I would do it in half the time robotic. Right? I mean, it's just that much faster. The room moves faster, the setup's faster, everything's faster. So that's the bottom line. So we do donor nephrectomies lap, because it's just the logistics of doing it robotic is tough, so they do get done lap, but otherwise it's all robot.
Good, great answers. Any question, please?
Is there consideration if you're doing arthroscopic nephrectomy? Like, is that
What?
anything, if you were at a hostile abdomen and an invasive tumor and you wanted to stay out of the abdomen but take the entire kidney?
Oh,
is there anything
retroperitoneal radical,
Yeah.
you're saying?
Yeah, we do that. Yeah, it's definitely doable. I would say, it's the same issues, but I would say oncologically, for example, I'm going to do a radical on a big tumor, I do that trans, and it's not so much the space. So I showed you actually that when we do a retroperitoneal approach, we're actually within Gerota's fascia. Transperitoneally, you can keep Gerota's fascia on the kidney, so that's one extra layer. So I think oncologically it's better to go that route, but we do a lot of radicals for people that really have bad abdomens. We've done radicals for cancer, but in general, my approach is trans if it's a big tumor. Yeah.
So for a really large mass though, do you have room retroperitoneal to do it?
Yeah, you do. It's already made the room. I mean, the tumor's made the room, so you're just working around it. So I would say, it's interesting that this perception that retroperitoneally there's not as much space, but one of the things that I point out is that when you're doing a transperitoneal case, you're about that far from the tissue. You're using the magnification. Most people do it, so you're really not that much different than if you were retroperitoneal. I think what happens is in the retroperitoneal space is that you just have to be a little more aware of your arm movements because they're tighter and they can clash. So that's number one. Number two, there are tricks you have to kind of develop to create tension. So when we do a radical, we'll do the hilum, and the first thing we do is we grab the ureter and we use that as a handle. We'll divide the ureter, and then we just use the ureter, and basically you walk up, and use the ureter as a handle, go anterior, posterior, and walk up to the upper pole. And it works well, but there's enough space, yeah, for big tumors. We've done polycystics retroperitoneally, yeah, polycystics because bad abdomens, yep, but it takes some practice, like anything. Any other questions? Well, everything, I think, today's been great. Thank you very much. First of all, I want to thank the faculty. You guys did a great job. Really appreciate you sharing your knowledge and taking the time to come here. I want to thank our sponsors, Intuitive, ConMed, Scanlon. I want to thank Veritas again for putting this course together. And then I want to thank you, the attendees. Thanks for taking the time to come here. I hope this has helped you, advance your renal robotic surgery plans. And we're all available for questions. Please fill out your evaluations. We need that for our CME. So fill out the evaluations. And again, I'm sure I'll be seeing you all at other meetings. But again, thanks so much for taking the time to come. Thank you.